Bismillahirrahmanirrahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, dear viewers, ladies and gentlemen. Happy and blessed Ramadan. Dr. Mohammed AlSheef, your host of Elixir of Life from Saudi TV Channel 2, is kicking off another inspiring and informative episode with our distinguished guest, aiming to explore new frontiers and bring you the most up-to-date information. Our program is filled with many inventive segments. Most importantly, our topic of this week is obesity, surgery, and fasting Ramadan. Stay tuned for a special episode. Once again, welcome back to Elixir of Life. Our next segment will be the topic of this week and our episode theme, obesity, surgery, and fasting. Obesity is a very common medical problem. It accounts for about 70% in our society and associated with many complications, heart complications, arthritis, sleep disorders. And our privilege to discuss this topic and to present my distinguished guest, Dr. Mohammed Abukhater. He is consultant laparoscopic and bariatric surgeon from King Fahd Medical City. Welcome, Dr. Mohammed.
Assalamu alaikum. Thank you for inviting me, Mohammed AlSheef, for this program, and also a special thank to the Saudi Channel, Channel 2 for inviting me to this program. Inshallah, it will be beneficial for the audience.
Yes, the pleasure is mine as well. Without further ado, we'll start. We have so many, interesting agenda. To start first, would like you to define obesity in simple terminology.
Yes, obesity is the abnormal accumulation of the fat in the body, which lead to impaired health and lead to many diseases. And always we measure the obesity by something called body mass index. The normal body mass index, how we calculate body mass index by calculating the weight of the patient by kg, by the height by square meter. So the normal BMI from 18 to 25. Above 25 to 30 we call it overweight. Then the classification of obesity, class 1, class 2, class 3. Class 1, when the obesity is from 30 to the BMI from 30 to 35. Class 2 from 35 to 40. Class 3 from 35 to from 40 to above 40. We consider the patient super obese if his BMI above 50 or 60.
Super obese.
Super obesity, which is common in some patients, and we deal with it.
Very beautiful indeed. Is it accurate method to diagnose obesity, or there are more accurate
There is
methods?
many measurement of obesity, but we consider BMI because it's easy to deal with this, and there is a standard international also measure, and also we consider surgery after a special measurement in body mass index, but we measure waist measurement, one of the also accurate measurement for obesity. Sometimes we measure both, but we consider BMI, body mass index, the most usual one used in practice.
Excellent. So just to, before we go deeper, so could you tell us about this, stomach, which is the home of sickness, and diet is the best, drug. This is small, organ that, estimated the size 15 by 30 centimeter square. So could you tell us more about this, stomach?
Yes, as we know, the stomach is one of, from the beginning of the entrance, one of the important system in the upper GI system, and which is the entrance of the food. when we digest the food, it starts from the mouth, then it's esophagus, but the main digestion started in the stomach, then goes to the small bowel. So as we know, this stomach is, we can see here, there is a fundus, there is body, there is antrum, and there is pylorus. There is around 4 parts. This is the actual. The stomach is rich of blood supply. There is 5 arteries, major arteries, supplying this. That's why, because a lot of is one of the strongest muscle in the GI system. It has contained very strong muscle to digest the food, meat and food and all other type of food. So really, it's not a simple structure. It's very structured. So when we do surgery, we need to know the anatomy very well. Otherwise, a lot of problem can happen.
Very
the shape of the stomach is like beer shape. It's around length is 30 centimeter, and wide is around 15 centimeter. It's a J shape, like J shape, but it differs from patient from person to person. It accumulates around 1 liter of fluid, the measurement, but in some patients it distends and get more than this. So it's different from person to person.
Very interesting. So that's why after heavy meal or feasting, we usually, most of the blood supply to the gut, about 25% of total body blood supply. That's why we feel drowsy after
because we lost some of the blood in the stomach.
Yes, excellent. So just the next, leading us to the next questions, what are the complications of obesity?
As you know, obesity by itself, it is not a big problem, but we are worried about the sequence of obesity. This maybe it cannot come maybe in the first few days or few months. After years of obesity, in the end, we'll get problems like there is measurement that diabetic mellitus, the obesity, the cause of type 2 that's related to obesity, around 80% of diabetic patients relate to the obesity. So it's a big problem. It's not a small problem. The second thing is hypertension, hyperlipidemia, sleep apnea. It's a great problem also. The patient feel difficulty while sleeping at home. When he sleeps, he has like suffocation. This we call it sleep apnea in medicine. This is another problem. Other thing, joint pain. You are giving more weight to the body, so the joint can be affected, especially knees, back pain, spinal pain. So it's a lot of problem can have. Patient will have, obese patient will have always knee problems. They have difficulty in walking. They have severe back pain. After reducing their weight, tremendous change in their lifestyle and their joint pain. So many other problems can happen, many other disease, but this is the most common disease I mentioned to you.
Very important point about these complications. Are they reversible after losing weight, whether by diet or exercise or by surgery? And could you give us life examples from your clinical practice?
Yes, thank you, Dr.sheef, for this question. This is important questions. Is this, if we do surgery or we do weight reduction, the patient can do the weight reduction by meal or by diet, by nutrition, by exercise. There is different way. We didn't speak about surgery only. Sure, this disease reversible. If they reduce their weight, all these problems can be reduced. It's important to consider, the patient should consider to do something for this obesity. Should not stay the patient should think his life should be changed, either by changing the lifestyle, doing exercise, follow nutrition at least for 6 months. Then if he failed to reduce his weight, he can think about surgery.
So this
is not the first line.
Yeah, so this is medical therapy for diabetes, for pulmonary hypertension, for sleep apnea, for obesity, hypertension. Can you tell us some examples that came across your mind that?
Yes, this is really very good questions, and also these not my example. It's also written in the literature how the patient improved after surgery. But I can remember very small child. He was around 14, 16, and he was having around 14. He started his problem in 14, but when he reached 18, his pulmonary hypertension. There's a disease called pulmonary hypertension. It's related to obesity.
Yes.
The pressure in the pulmonary vessels and it gets very high, so they get cardiomegaly, and they have difficulty in heart. They reach the heart failure. By treating the obesity, by sure these patient diet will not be beneficial with this, so they need surgery. After we assist the patient with the cardiologist, pulmonologist, and anesthesia, we put them in surgery. especially children, even kids, many kids even below 12. This pulmonary hypertension will be reversible.
So patient
before they develop fibrosis in that vessels.
Cured.
They get cured. They get
so the patient was requiring oxygen therapy?
Home oxygen all the time, home oxygen. He cannot stop it. Now, when we do the surgery and he recover from the surgery, after 6 months or even less, they will stop using the oxygen all the time.
That's very interesting.
It's like magic.
That's very interesting.
I'll give you another example, sorry to mention, the diabetic patient, especially diabetic patient. When you do the surgery, immediately they will stop, especially after gastric bypass. Immediately after the surgery, they will not use medication. Their sugar level will improve because there is a hormonal change immediately. We will not wait after 2-3 months. So immediately we adjust, especially in type 2 diabetes mellitus, we stop the medication totally.
Even insulin?
I'm speaking about type 2. Insulin, we need to reduce the size. But after maybe a few months, the story is different.
Sure, yeah. So they can be off,
oral medication.
Oral medication or even insulin for type 2 medications.
Nice.
Sure. Very interesting. So now we are in the month of fasting, month of Ramadan. What's the expected weight change during Ramadan?
A normal person, usually, if we fast in real way and not, I see majority of the people after breaking the fast, they eat everything, which we have wrong habit, even ourselves. So they gain weight, unfortunately. But if we fast and we take our diet in the right way, majority of people reduce to 3 to 4, 5 kg, normal person. This is really a month to try to reduce your weight. You have not to eat too much sweet and all this thing. But we see our habits, our life, we eat too much coffee and with the Arabic coffee and sweet dates, we eat in very big number. But majority of the people, if he's interesting to reduce it, he can reduce 3 to 4 kg easily. I think this is thing studied also.
That's evidence-based. I think it's important not only that we have unhealthy, unbalanced diet, again we have physical inactivity or sedentary lifestyle. So we do eat breakfast and we sleep, we have reverse sleep pattern, maybe the dramatic lifestyle change.
Right. So also exercise important. Even during fasting we can do some exercise, especially early morning or before fast. Some people like to do exercise before breaking the fast. You have to keep your exercise maintained all the time.
Sure.
Otherwise you cannot reduce weight. It's not only diet alone. It needs a lot of work, really.
Excellent. Now we are coming to the most important. We know the consequences or sequelae of obesity. What's the management? What's the first line management of obesity?
Excellent question and very important to know. Unfortunately, you asked me a very important question. Sorry to say this in Arabic, but the patient some patient, I didn't say all of them, he think now he's obese, he saw one of his relative or a friend, he went for surgery, I will go for surgery. This is wrong. Patient should understand there is many modality of treatment of bariatric, obese patient. The first, you should start with diet. But you have to see some people who's trained and he know how to deal with the obesity diet, not any nutritionist. Some nutritionists, especially clinical nutritionists, who have experience in dealing with the bariatric patient or obese patient. So first of all, you have to see a nutritionist, follow the diet for at least 6 months before changing this modality. There is some drugs under special persons, special physicians, we call them bariatric medicine. They can start some FDA approved drugs or approved drugs. Then they can go for these medications. Exercise, changing the life habit, all this. Always I mention this thing. In the end, if he could reduce his weight, it's excellent and it's much better than surgery. In the end, some patients cannot, they have super obesity, so they cannot reach to the target. At that time, you think about the surgery.
Okay, that's very important. So bariatric surgery is not the first line
it's the last
treatment.
It's
the last resort or last option. Because I think there is misperception of the public that everybody is, going for bariatric surgery. It's like a fashion, luxury rather than necessity. I think that's excellent.
Thank you, Dr.sheef. Also, this is important things to know. When we treat the obesity, we should not treat it in one team. They should, what we call it, multidisciplinary team or clinic. The patient should go through steps before he go to surgery.
Stepwise, okay.
If we go as international standard of treatment, this is the way to go for treatment. But if it goes to the patient option, this is really harmful for him because patient cannot understand. Some patients, I didn't say all, Now patient educated, he know all these problems. Majority of the patients, they always try some modality, but when we should also confirm ourselves, he try in right way or a wrong way. How it's the wrong way? Maybe he did the diet by himself. He just picked it from the internet and just apply it to himself. Maybe this is not good, but if he saw a specialized person, he will know which diet he should strict on it, and after that he can test himself. And nutritionist, he said this patient cannot. He tried his best. He reduced only for a few kg. He could not maintain his weight reduction. At that time, we can go for surgery if he reached to the target of BMI, as we'll mention what are the indications.
Sure, excellent. Because most patients are looking for quick, hard and fast method to lose weight.
You mean magic?
Yeah,
magic things.
But they don't want to
go on the steps.
Yes, they don't want to go for exercise, for diet. They want just to go for surgery, which is the
magic touch.
Magic touch. But the important just that to bring us, okay. Now we are, let's say, after we have exhausted, the diet and exercise, and now we come to the third line, okay, management, or fourth line, surgery, obesity surgery. Do we still need diet for that? So patient already now we are, reaching to the option of surgery. So still we need diet and exercise, or it will eliminate them, okay?
This is an important question, really. Every patient need to know these things. Any obese patient should understand this thing, because if you do the surgery and you did adapt the patient in special way of eating, he should understand what diet he make him obese, what diet he can reduce weight by it. If he didn't understand that carbohydrate can increase his weight, sugar, and what type of food, he need to know how to calculate his calories. Usually it's very difficult to the patient to calculate, but he should understand. By nutritionist he can explain these things. But if he didn't get these points before surgery, sure, he will not get it after surgery. And you will see some failure. As international standard, the weight regain after surgery, you reach up to 25%. It's a big number. It means there is failure of 25% after surgery. The patient will regain weight again. So it's disaster. You're putting the patient in the risk of complication and the risk of even death in some patient. And the patient, unfortunately, in the end, he will regain weight again. So he need to change his lifestyle totally. Okay. He should be in good diet. He should do exercise forever and diet forever. Then the surgery will help him, sure.
Excellent. So even before surgery you need it, and after surgery you need to adopt a therapeutic or healthy lifestyle, weight and diet. So this is a must before and after surgery. Now we are coming, what are the indications of bariatric surgery or obesity surgery?
It's an important question also. What are the indications if the patient BMI is 40? I mentioned what's BMI in the
body
beginning
mass index, yes.
If the body mass index above 40, we calculate it by weight and height. Now everybody, there is special format, there's calculator in the internet, anywhere. You can calculate, putting the weight and the height. Weight in kilogram and height in centimeter or meter square. Meter square. If the calculation came above 40, without comorbidities, he can go for surgery.
Without other medical illnesses?
Without any medical illness. In case his BMI is 35 with 1 or 2 of the comorbidities, what are the disease can associate with the obesity? Like diabetes mellitus, hypertension, hyperlipidemia, sleep apnea, and joint pain or degenerative disease.
Yes.
Osteoarthritis.
Or spines.
If one of these comorbidities, if the BMI is above 35, he can go for surgery. Otherwise, below that, we should, as the international standard is not. But now there is few studies that diabetic patient, if BMI above 30, they can go for surgery, even if their BMI 30, to cure diabetes mellitus.
To cure, because, okay. So that's the rationale, okay?
In some cases.
So because it's a cure for type 2 diabetes mellitus,
we go for surgery, even BMI 30.
So that's a new, evidence, okay?
Evidence in the last years, but still the standard is 35 and above, but still in some, especially Asian patient, we go for these, we lower our limit in case of diabetic patients.
Excellent, okay. Now we are coming to what are the types of bariatric surgery.
Yes. As we know, the bariatric surgery classification, and we classify into 3 classifications. Restrictive bariatric surgery or obesity surgery, then malabsorptive surgery, then mixed between both type. So we have restrictive, malabsorptive, and combination of both. So I will give you example of restrictive. What we mean by restrictive, we just cut the stomach. We play with the stomach only. We operate in the stomach only. We make the stomach smaller, so it will not accommodate too much food. This is the idea of restrictive. Example like gastric band. Putting band here. Here is the stomach. If I can explain it to you.
Yes, go ahead.
We put a band over it restricts the entrance of the food. Now this operation is not anymore obsolete because of its complication. Another operation called VPG. The most common procedure done in Saudi Arabia called sleeve gastrectomy is a restrictive procedure.
Excellent.
Up till now is a restrictive procedure. It's the most common operation done all over the world. In Saudi Arabia is the maximum also. Majority of the cases now. The latest statistic of this operation, sleeve gastrectomy, is around 60% worldwide. So it's a very common procedure, and people like it because the complication is less. We'll mention later on. The second operation, malabsorptive. Pure malabsorptive. Now it's going down. Not everybody is doing this operation, like duodenal switch, biliobacteric diversions, mini gastric bypass. This is called complete malabsorptive. The combination of both restrictive and malabsorptive, what we call it, gastric bypass. It's a very common procedure also. It's around 40% worldwide. This is the procedure. When we decide for operation, we will mention it.
Yes. Just thank you, Dr. Mohammed Abukhater. Now we welcome Miss Leen. She's a clinical dietitian. Hello, Miss Leen.
Hello. Salam alaikum.
Alaikum salam wa rahmatullah. Happy Ramadan.
Happy Ramadan to you too and to Dr. Mohammed Abukhater.
Thank you very much for joining us. I will ask you a very important question. What are the dietary advices for bariatric patient during Ramadan?
Yeah, in general, always we are like the other days. They have to consume two to three small nutritious meals each day. Usually in Ramadan it will be suhoor, iftar, and dinner. Also include one snack each day, preferably a piece of low glycemic index food or low fat yogurt or milk. Also all the main meals should contain mostly lean protein food and vegetables with a very small amount of carbs. Also they have to focus more on carb choices to be like whole grain. Also they have to focus more on iftar meals. They should not take high portions because usually people after fasting they like to eat high portions in iftar, which is not preferable at all, especially with bariatric patients. Also they have to eat slowly to avoid indigestion, heartburn, and nausea. When they will break the fasting, they have to take something warm, like soup. They have to wait about 10 to 15 minutes before eating to avoid food getting stuck. They have to avoid also empty calories like sweets, pastries, fried foods, fatty foods, and fruit juices, which will contain high amount of sugar. They have also to limit sweets from about no more than 1 to 2 times per week. Also avoid eating, drinking at the same time. Also at the same time, they have to focus on the amount of fluid drinking, like especially it should be water and free calories, like mint, herbs, some of these things, so they will not get dehydrated. Because usually the fasting hours, it will be long for them. They have also to do not take caffeinated beverage, and if they will, should not be on sahur time. They have also to continue the vitamins as prescribed. Also regarding the exercises, it should be about 2 to 3 hours after iftar, not during the fasting, because maybe they will have hypoglycemia or they will get dehydrated, which is not preferable.
Excellent. Do you want to add anything, Ms. Lee?
Usually this is the most important, and one point I like to add is, in suhoor they have to focus more on the protein they will take. Potassium sources like banana, dates, usually it will make them not feel too much thirsty. They have to focus also on the water they will take. They have to manage the suhoor meal to be at the late night, not they will not take it about 1 to 2 hours before Fajr time, because they will have long time and they have to get more the nutrients it will stay with them. Also, especially suhoor meal should not contain caffeine at all for them.
Very beautiful. What are the best timing for medications during Ramadan? Because they require, medications for at least 6 months after obesity surgery.
Usually it will depend on the physician which time he will prescribe it. But for example, if the vitamin, it will be within the meal, usually after iftar.
Thank you very much. What's the take-home message you want to say, Ms. Leen Abdulkarim?
I'd like to thank you for your invitation, and I would like to thank you, Dr. Mohammed Abukhater, for the valuable information.
Thank you very much for your insightful and valuable information. Thank you.
Thank you very much.
Goodbye. Okay. Now, after hearing, Ms. Leen Abdulkarim, would you like to add anything about, dietary advice for bariatric patient during Ramadan?
The clinical nutrition, Ms. Leen, she explained very nice the part of nutrition, and they are much more expert than us. But I have some concern, especially my patient, when they come to me, they ask me when I can start fasting. Usually, especially after sleeve gastrectomy, the common procedure done here in Saudi Arabia, I advise them always. We have 6 stages after surgery. The patient should go through it, then they can go back to normal diet. But I ask them if they have no comorbid, if they have no diseases like major diseases, they are normal person, just obesity problem and this thing. If they are diabetic also, I allowed them, if they are type 2 diabetic, I allowed them to fast. The first stage is water, it's 1 day after surgery. The second stage is a clear fluid for 3 to 5 days. Then the third stage is the full fluid diet, like juices, yogurt, milk and all those things. Then the fourth stage, if the patient reached the fourth stage, I allowed them to, or third to fourth stage, I allowed them to fast. But very important, I give them always advice. And I like the clinical nutrition to give them this test. He should test himself from the break of the fast up till suhoor, if he can accommodate 2 liters or 6 to 8 cups of water, 4 to 6 cups of water, only with juices. If he can accommodate this in this period, it means you're able to drink this amount of fluid, at least 2 liters, then he is able to fast. If he felt he tested himself 1 day and he could not accommodate this type of fluid, I think he should delay his fasting. Especially if he did the surgery just before Ramadan or anything, I didn't advise him to go for fasting. If he tests himself, especially, he should not be dehydrated. During the break time from, breakfast from Maghrib to Fajr prayer, if he could accommodate 2 liters, then the advice what Ms. Leen mentioned is very important to go through it. He should have at least 3 meals with 1 snack every day. The first meal at the iftar, the second meal at evening, and the last meal at sahur, and one snack in between them. Other things, the amount of juice and fluid he should divide it in sips and all these this time. Other things also, when he break his fast, it's very important. He should not go for meal immediately. He should take soup or water, something warm. After 15 to 20 minutes, he should go for food.
Warming up, okay. Warming up.
Warming up. This is very important for them.
They should not feast. They should not.
Yeah, sure. They have to feast, especially after bypass patient. If they do this bad habit again, feasting, they will get dumping syndrome. And they will get hypoglycemia, cramps, what they call it, vertigo. It's very, very difficult feeling, especially who do gastric bypass.
What's dumping syndrome?
Dumping syndrome, patient will have sudden secretion of insulin. What will happen? They will have hypoglycemia, they will have vertigo, abdominal cramps. It's a very bad feeling,
Is it common? Or
it's common after gastric bypass.
After gastric bypass. So, Dr. Mohammed, do you advise bariatric patient to undergo bariatric surgery or obesity surgery just before Ramadan?
It's not harmful if there is no other way, because if he go to a governmental hospital, there is big waiting list, and if he did it before surgery, it's not harmful. It's a chance for him to reduce the weight. Just he need at least only 2 weeks not to fast. After this he can fast easily.
So 2 weeks usually after surgery they should not fast?
After this, if everything went smooth and he tested himself
Excellent.
and follow with us, it's very important. Another point, medication. This is very important, fasting. We have very limited time from, we fast 16 hours, so we have limited time. So he can adjust his medication. What medication patient will require? Multivitamins. Multivitamins, he can take them at sahur time or iftar, do it up to him. But as I mentioned, so it should be between meals. The other medication, like some stomach medication to prevent heartburn or reflux, I advise them to take it early at iftar time. Before, after the drinking water, he can take the medication. This reduces the acidity and reflux. So after that, he can take his other medication like antihypertensive medication and all other things he can get them. But for diabetic patient, I advise he should follow his endocrine or diabetic doctor to adjust his medication, because he will require less medication, less insulin. And usually after surgery, we reduce the insulin level. And for the oral hypoglycemic, we reduce them. If they're using 3 tablets, we keep them on one medication. The endocrine physician also will help us to adjust this diabetic medication.
Dr. Mohammed, why it is difficult for bariatric patient after obesity patient after undergoing bariatric surgery to fast? Why it's difficult to fast?
Yes, it's a really important question for people. When we operate the patient, their stomach size, like before in sleeve gastrectomy, will take out of the stomach around 80%. So 20% will remain inside the body.
80%. So like this, if you demonstrate.
So if we will cut, sorry, I'll show you here. So we will cut from here. So all this part, the fundus and body, will go out. So only small part will remain, tube-like structure. It will become like esophagus. So by this, we are reducing the size of the stomach. So it will not accommodate too much fluid, too much water. It needs time to adjust. So by 2 weeks, we hope he can adjust the fluid we want. That's why we didn't start immediately, because the stomach is newly resected. There is stabler, there is anastomosis, there is eclipse. There is still it get healing. It needs time to get healing. By 2 weeks, the stomach is strong strong enough to accommodate this type of fluid. If it does not, patient cannot tolerate, he develop vomiting, he develop nausea. He's not tolerating food, he should not fast. We should not restrict the time by the time we mention to the patient. Himself, he can adjust himself by the amount of the fluid he's getting.
Yeah, Dr. Mohammed, when do we advise bariatric patient not to fast? So let's say contraindication for fasting.
Yes. Okay. First of all, if the patient is diabetic, not controlled diabetic, especially in insulin, usually even normal person, if they are insulin dependent, they are not allowed to fast. So the endocrine physician will also, the same indication, we do it for that patient during, before surgery. The same thing goes for, maybe they need more time, to even years, not years, months, to accommodate his, so maybe he'll remain 1 year without fasting, maybe.
1 year without fasting.
Other things, it's contraindication for fasting if the patient is in a lot of medication, like what we call it, epilepsy, other medication.
Polypharmacy, yes.
So it depends up to the specialty. So when it's controlled, we can allow. Like any other disease, it's not specialized by bariatric. The disease, the medical problem before surgery is the same applied for that.
But vast majority of patients, they go for fasting.
Only who is vomiting, he has problem, bleeding, problems, complication. When they have complication, surely we should not fast.
Anyway, what about exercise? Best timing for exercise for bariatric patient during Ramadan?
As I mentioned, after surgery, important to choose the time. As she mentioned, Ms. Lean, she mentioned that should not go before breakfast. This is true, because maybe they are not drinking, they are going to lose more fluid. So it's better after fasting, because if he needs fluid, he will get it, especially at night. I prefer
after breaking fast, you mean?
Yes, after breaking fast. It should be like after Taraweeh prayer, he can go to the field, and the weather is less hot, so they will not lose too much fluid. So they should start exercise after 3 to 4 weeks from the surgery, not immediately.
Not immediately,
Yes.
3 to 4 weeks from
after
surgery.
from
And after meal, after breakfast, immediately, or after 3 hours?
No,
or
after the digestion of the food, maybe after 2 3 hours from the meal.
for me, they can go for exercise. That's very important. I think you brought us, you brought up very important, problem that you mentioned that there are different kinds of surgeries, restrictive and malabsorptive, and there is combined, okay? What decide the modality of surgery for each patient? So can we go for, let's say, sleeve gastrectomy for all patients, or we...
Yes, this is very important. Many patients will come to your clinic, I need this type of operation. I need sleeve.
Sleeve, which is
This
the fashion.
Everybody will say, I want sleeve. Patient has right to choose his surgery. He's going to follow, he's going to suffer, we respect patient opinion.
Yes.
But also, we should not harm the patient. If he push you to one surgery, you should always refuse. Why? Like especially a patient who has hiatus hernia, hernia between the diaphragm and the esophagus. The stomach is herniating inside the chest. They are contraindication, in my opinion, for sleeve gastrectomy. Patient, even if he has no hernia, have severe reflux. We didn't advise them severe reflux.
Yes.
They have acidity, heart pain, severe
Hyperacidity,
heart pain.
yes.
If their symptom is too much, sleeve will increase the symptoms. We advise them to go for bypass.
Great.
In these patients, after repairing the hiatus hernia and repairing the hiatus hernia, then we can do the gastric bypass. But I didn't advise to go for sleeve gastrectomy.
Good.
So,
Excellent.
patient who has comorbidities like metabolic disease, like diabetes, hyperlipidemia, hypertension, the patient with metabolic disease, better for them to go for bypass. But if they refuse and there is no contraindication for sleeve, we go for sleeve gastrectomy. But we advise them for diabetic, especially diabetic patient. As we know, this, when we do gastric bypass, the GI peptide of the GI system gets stimulated and stimulate the pancreas and secreting the insulin. One of the theories of the mechanism of improvement of insulin secretion by gastric bypass, and it's proved in some study. So it improved the bypass more than sleeve gastrectomy.
So superior.
Yeah, that's why we call them metabolic surgery. We didn't call them a restrictive surgery. It improved the metabolic disease, and the literature improved that one. It improved the diabetic, and we speak about long-term follow-up. The diabetics is better in these metabolic surgery than restrictive surgery.
Excellent, indeed. What are the anticipated complications of each type of surgery?
It's a really important point also. You're doing surgery for any patient, sure there is percentage of complication. We cannot avoid it. Especially the 3 most important complications. Leak. Always patient afraid, always ask the surgeon, what's leak and what happened, how I can prevent it. Leak, it means after we cut the stomach from here, it will leak from the stapler line or from the cutting side.
Sure.
So the food will go inside the abdomen, the food and the water and secretion. And this will cause abscess, peritonitis and infection, and patient can get seriously sick and get a lot of problem, and he need emergency management. Other thing, bleeding. And lastly is the thrombosis. They get DVT, thrombosis, and what we call it, the thrombosis thing. It can happen anywhere in the body. For this thing, we are trying, doing our best by help of God, Allah, to prevent this thing. How? Not to prevent, to do prophylaxis. What we do our technique in very right in the right way. The other things, after the surgery, we do test to that leak test. We do X-ray to confirm there is leak or not. If there is no leak, we allow the patient to drink. So in some situation. Other things, for bleeding, we control the bleeding by clips, by suturing, to prevent the bleeding from the... We have to be meticulous using the sophisticated instrument, the best instrument in the world we use to prevent that. Other things, we control blood pressure before surgery. Will not get, when the blood pressure gets higher, there is chance of bleeding. For thrombosis and DVT and PE and all these thrombosis events, we control them by what? By giving some medication like heparin to make the blood thinner. We give them before surgery, we give them after surgery, and we give them at home also. We teach them how to use the medication. It's like insulin under the skin, subcutaneously. So we even educate the patient how to use the medication for at least 2 weeks after surgery. And by this we reduce the incidence of thrombosis. This is the 3 complications. If we need to also, the problem when we discharge the patient, we need to tell them about the symptoms. This is the most important.
How to recognize? This
How
is
to
the
recognize.
next question. How to recognize these complications?
How to recognize this complication? Patient will go home, will give an appointment in the clinic maybe after 1 week of the surgery to just see, or 2 weeks of the surgery. But the problem, some patient will think, I will just follow when my appointment comes to the clinic. No, we give them instruction paper or booklet. In that booklet, we mention, in case you have abdominal pain, more abdominal pain, fever, temperature, you have higher temperature, you should have your thermometer. If your temperature above 38 degrees centigrade, you come back to the emergency room. You have more abdominal pain than usual, slight abdominal wound accepted with the medication. But if your pain is getting higher, you have chest pain, means there is chance of thrombosis or BE. You have leg pains. You have what they call it tachypnea, tachycardia. This is a sign of leak. You will feel palpitation. Patient will feel his heart is pumping too much. It means you have some problem. Contact your doctor again in the emergency room. If you have temperature, don't take it. If you have tachypnea, you're breathing very fast.
Rapid, fast breathing.
Fast breathing. No, consider this a problem. Because the problem can start with this small thing. You think it is nothing, but there is a problem. If we know these points, the patient knows these points, he should contact. When we discover the complication in the beginning,
early,
very easy to treat. But if he comes very late, it will be very serious for him and it will be danger for his life. So it's very important to recognize this complication. Physician rule, surgeon rule, very important to explain this to the patient. If the surgeon did not explain this thing, it's a problem. Patient cannot know these problems.
How common these complications?
Yes.
So bariatric surgery generally is safe.
It's very safe procedure, but the problem, complication you cannot prevent. All over the complication, they are, if you calculate all the complication together, they are much. But let me speak about every one by each. Like if you go leak, it's less than 1% nowadays. Before it was around 5%, 2%. Now from 1 to 2% the leak, even less than 1%. So we need to explain to the patient before surgery. He should know there is chance of leak and how we can treat that leak. Alhamdulillah, now the advance of medicine like stent and intervention radiologists, especially in tertiary care center or specialized centers who have the facility to treat that complication. That's why a big hospital can accommodate this, some type of bariatric surgery, because they can deal with these serious complications by putting a stent in the stomach and draining the collection in the abdomen by intervention radiologists. So these special teams or physician can help to treat these complications. The other complication, also the bleeding, also around 1%, DVT and PE around also 1%.
So all relatively low, 1%.
It's a low complication.
So the most, I think, important and key, and the complication is that to choose your bariatric surgeon, because could it be done by general surgeon or only should be by certified or a qualified bariatric? I think this is important.
It's an important question. Yeah, a qualified surgeon, there is no doubt about it.
What's a qualified definition? Okay,
a surgeon who get training, training in the bariatric program. This is no doubt important. But also, surgeon alone cannot do the work. It needs the center also. The center should be also recognized center who have the facility and the system allows him to do this operation. You cannot go and do the operation in the center who has no facility of anesthesia, who have no facility of OR. So the equipment, the surgeon, the supportive team, the nutritionist, psychiatrist, endocrinologist, thrombosis team like you, sometimes we get your help when there is complication.
So multidisciplinary team approach.
Multidisciplinary. If you have this approach and you have the center and facility, then you can do the surgery.
So I think we highlight very important. What's the training? It's is it 1 month or 1 year or 2 years?
At least 1 year, 1 to 2 years. At least you have to get training after general surgery.
After general surgery,
yes, at least 1 to 2 years training, then experience at least 2-3 years to be a qualified surgeon. You cannot be a qualified surgeon from when you graduate on fellowship. You will go and work, do some number of cases, then some team have to evaluate you. In the end, as we have the Saudi Council, will evaluate your level to give you a certificate of practicing or not.
So it's the right of the patient to ask his surgeon.
Yes. Are you qualified from Saudi Council or not?
Or you are just practicing it from one rotation or just 1 month or
I
2 months
cannot
training?
prevent the other surgeon to do this is their right also.
But the patient has the right.
The patient has right, but this is, you ask me a question, so I have to answer it.
No, no, absolutely. That's should be done by the, I will say, highly qualified, trained, surgeon, not by anybody. So important procedure that usually done before obesity surgery. We ask patient to lose weight first, okay, before going for surgery. What's the rationale behind this?
Excellent question. Some patient will ask me, why you want me to reduce weight before surgery? Are you giving me some challenging, you want to let me fed up and leave? No, we explain for them. It's not for joke. It's not for making you difficult. Even as international standard, any patient will do the bariatric surgery should go in weight reduction. Why?
What's the weight, expected weight to lose?
At least 5 to 10% minimum.
5 to 10% from the total body weight?
Total body weight. It's difficult 10%, but minimum 5. Now we get proof for that. Before we are saying there is no clinical or research proof behind this rationale, as you
scientific
mentioned.
evidence.
We found that patient who reduced his weight before surgery, he avoid the high calorie diet, and he adopted a high protein, low fat diet and low calorie diet. This is the most important thing. By this, the fat in the body stored will be reduced, especially in the liver. Liver size will reduce in size. This will make your operation easier for the surgeon and easier for him. So the operation time will be less, number one. Because if he has a huge liver, you cannot do the operation.
But what will do the huge liver?
Technique-wise, majority of the obese patient, they have huge liver, hepatomegaly.
Fatty liver.
Fatty liver. Huge fat, too much fat. As there is fat, more fat in their body, also their liver accumulate fat also. As we know, the left lobe of the liver is above the stomach. Here is above it the liver, right? If you can see the space.
So we can zoom on
in that space. We can see there the liver over that stomach. So if we reduce the liver size, so we can have a space to do our surgery. In the stomach. As we know, the stomach is behind the liver from the left side. Other thing, the fat over the body abdominal wall. Omentum and also the abdominal wall. If we reduce the fat, we'll make easy to inflate the abdomen, so our operation will go smoothly. Now, a new trend in before surgery, we go for what they call it, the fluid diet. We put the patient, if we feel difficulty, the patient cannot follow our nutrition, so we put them in special diet from 2 to 4 weeks, only fluid diet. What type of fluid diet? They will get special milkshake. I will not mention company names, but they are special formula.
Formula, yes.
This formula, it contains high protein, low fat, low calories. Contain all the requirement the body needed.
Yeah.
So patient will not eat anything in this 2 to 4 weeks. He will take that milkshake 3 times per day. In between there is vegetables and soups. By this, patient will not feel hungry, sure. And the majority of my patients, they easily adopt the system. Excellent. And really, I tell you my personal experience. Now, it's proved by scientifically that it reduces the liver size. Sometimes I do patient, I could not put them in that regime. So I took them to surgery without that regime. Their body weight may be 40, not too much. And patient, in the same list, I'm doing maybe 3 or 4 cases today, right? I put 3 patients in that diet, fluid diet. And 1 patient did not put diet. Why? Because due to some communication problem. And so that patient, I did not put him. I'll tell you a real experience. Her BMI was 40. And the other 3 patients, their BMI is high, super obese, 50s, 45, 60. So all of them, they went to the fluid diet except that patient. All the 3 operations went very easily because their liver is small, and I did the surgery even with less port, not 5 ports, 3 ports or 4 ports. That patient, I feel too much difficulty. The liver was huge and her weight is not too much. But because she did not go through that system.
So that's
So I advise patient to really, even if they do it in private, they go in fluid diet. Now we push the patient in fluid diet to
standard of care right now.
Really, it will help the patient.
Excellent point. So what's about the role of intraballoon gastric, insertion?
Oh, you asked me a question not related to my specialty, but I will tell you. This is intragastric balloon. It's here. If we can open the stomach.
Can you just zoom to that one?
Yes.
Could you zoom? Okay.
Yes. Here, if we can see, the stomach is it's a cavity.
Intragastric balloon.
So what we put balloon inside.
Yes.
This it will reduce the intake But a patient can reduce few weights, but is not good for higher BMI. For the patient who need to reduce 5 to 10 kg, or he want to adopt a special way. The advantage of this procedure, it's not surgical. It can come done by endoscopy. Endoscopy by the mouth. He will insert it by endoscope, especially in the GI surgeon, gastrointestinal, not surgeon, I mean physician.
Yes.
He will put the patient in the under sedation. He will not go under anesthesia. He will just pass it inflated with saline. And we put with the saline some contrast in case it has problem, rupture, patient can notice that one.
Is it a bridge to bariatric surgery, or is not used
It's
as a
excellent
bridge?
question. It's used for the patient who want to reduce very few kgs or even more, for high risk patient even, and bridge before to, sometimes we use this as a bridge to reduce 5 to 10 kgs. Then after this we remove it and go for surgery.
Dr. Mohammed, I would like you to give us the take-home message, okay, of your fabulous and insightful talk.
Thank you, Dr.sheef, for all the discussion we did, and I hope it will be beneficial for everybody. The take-home message, before deciding to do the surgery, you need to change your lifestyle. You take it as responsibility by yourself. How? Don't say it's difficult. It's not difficult. You need to follow the instruction of your nutritionist. Other thing, do the exercise, you can do it. Like, you don't do difficult exercise. See, if you are having joint pain, you go to the gym, go to the swimming pool. See that any exercise fitting your weight. But you should start exercise even before surgery, if you can. If you cannot, okay, in the future, you will have the chance to go for exercise. Second, patient, trust your surgeon. Trust your surgeon to choose the right operation for you. Don't force your surgeon to do a surgery which is not good for you. If he advises you a surgery, he knows what surgery is beneficial for you. Sure, you have the right to choose, but ask your surgeon, please, what you can advise me. In the last, in Ramadan, in this holy Ramadan, and Ramadan Mubarak for everybody, and I hope this fasting will be good for the patient and the reduced weight. If you did the surgery before Ramadan and you are now fasting, it's very important to concentrate in the fluid. If you can drink fluid around 2 liters between iftar and sahur, you can continue your fasting. Excellent. After you reach the 3rd or 4th stage of your diet.
Thank you, Dr. Mohammed Abukhater, consultant laparoscopic and bariatric surgery, for such a wealthy and fruitful discussion, and looking forward to see you again our program.
Thank you very much, Dr.sheef, and to the channel too, inviting me here. Thanks.
Now we are coming to the last segment of our program, Health Benefit. To see more details about this report, please stay with us.
My top 5 general Ramadan tips for keeping healthy and happy this Ramadan. Number 1. Drink 8 glasses of water daily, from iftar to suhoor, to prevent dehydration and constipation. Number 2. Sleep for 6 to 8 hours a day to get sufficient mental and physical rest. Less sleep means you will feel tired during the day, which in turn leads to less productivity and activity. Number 3. Have a balanced, varied iftar, which incorporates dates, soup, salad, main dish, fruits, and a small piece of sweets. Number 4. Walk or participate in some kind of physical activity. Number 5. Have suhoor to fill your body with energy and help regulate your blood sugar levels. An example of a healthy suhoor would be 2 glasses of water, 1 at the start of the meal and 1 at the end, a small bowl of muesli, approximately 50 grams, with low-fat milk or yogurt, topped with some fresh fruit or canned fruit. But if using the canned fruit, be sure to use the fruit in its natural juices, as opposed to the canned fruit in syrup. Finish off with 3 dates and the second glass of water. For a dairy-free option to suhoor, include complex carbohydrates, equivalent to 1 cup of rice or spaghetti, 2 slices of bread, or half a loaf of Arabic bread. For the protein, 60 grams of meat, 2 eggs, or 1 cup of fava beans, otherwise known as ful. The meal should also include some vegetables, approximately 1 cup, and 1 piece of fresh fruit. Avoid the heavy desserts, such as kunafa and baklava, fatty and fried foods and spicy foods, which all increase thirst.
Once again, welcome back to Elixir of Life. Thank you for viewing our show, and I wish you found it useful and informative. With this, we are coming to the end of our program. Before that, I would like to thank our great team, starting by Mohammed Al-Qasim, sound, Yazid Al-Husseini, cameraman, Khalid Walid Diko, preparation by Rahab Khalitit, and our director, Turki Al-Huwaiti, and presented by me, Dr. Mohammed AlSheef. Until next week, we wish you a pleasant week ahead. Looking forward to see you next week. Assalamu alaikum wa rahmatullahi wa barakatuh. Goodbye.